Hey everyone, how's it going? Let me know if you can hear or see me. Doesn't look like I have anyone here viewing me right now, so. Okay, I'll give people a few minutes. We'll go from there. Alright, looks like I got someone back in here. Can you let me know if you can hear or see me? Make sure everything's working correctly. Sure, most of you are watching in a big room, so that's probably what's going on, if I had to guess. Hmm. Alright, can anyone give me like some sort of confirmation that you can... Any kind of signs of life, perhaps? Just make sure someone's here so I can get started. All right, thank you, Rosina. Are you guys watching in a big room together, I imagine, after the test? And hopefully the exam went well for you all. Some people get in late. Stinks. Give them a couple of minutes, but I wasn't sure how many people are all watching in the same place, so. But yeah, so the exam I'll go through and check it out and see if there's any givebacks or anything, if there's any high misses. And then I will post up an announcement regarding the results and everything. So hopefully it was fair and went okay. But opinions may differ depending on which side of the exam you're on, whether you're giving it or receiving it, I suppose. Okay, well, people can catch up certainly if they need to. The joys of YouTube here and live streaming. All right, so I'm gonna get started recording here, and hopefully everyone has access to the material. Obviously, if you took the exam, then you have access to the week, so you should have your oncology slides available to you. And so yeah, I'm just gonna get into it, and you know, feel free, post up on the chat and the sticky board, anywhere's fine. You know, you gotta encourage lots of interaction. Helps make things more interesting for both of us, I feel, but. All right, so what is cancer, right? Cancer is basically having this sort of unregulated cell growth. Cells are just kind of propagating ad infinitum, as it were. And this is usually due to a lot of things. So, for instance, like growth factors may be upregulated. You can have things like, estrogen causing growth of things like breast tumors, for instance, right? You can have things like the P53 gene being downregulated, and that's normally a gene that triggers off apoptosis, which is, the programmed cell suicide, basically. And they also lose something called contact inhibition, which is basically when cells normally get kind of crowded out. They send a signal that says, hey, I probably don't need to replicate anymore because I'm being surrounded by other cells of the same type. You can lose that and they'll just continue just kind of replicating, right? So we're going to see that while certain cancers may have strong associations with, certain exposures or certain genetics, for instance, a lot of times we don't know why people really get cancer, but essentially what we're going to see is you'll have this sort of initiation phase where maybe you have the genes that predispose you to it, you have some sort of environmental exposure, something that will sort of select out for these cancerous cells that will kind of cause them to start to grow. And then you'll have things like promotion where you'll have further propagation of these cells. Usually this is due to things like exposure to environmental issues, like, if you have certain occupational exposures that can happen over the course of years, it can lead to some of these cancers. So for instance, like if you worked with maybe construction and you had exposure to asbestos and they have mesothelioma or something, and then they'll have further progression of these cells proliferating, and then you'll see where they can then start to invade other local tissues or maybe disseminate out and metastasize into places that are totally not related to the original cell type. So for instance, if you have like bone cells all of a sudden showing up in the lungs, that's usually not normal, right? And so what we're seeing here is usually due to several different factors here. So for instance, things such as inducing angiogenesis, right? These cells need nutrients and a blood supply just like any other cell, and so they're going to help to promote angiogenesis. And this is actually one way we can treat these types of cancers, is by trying to limit their blood supply. And so we'll look at some different options that may be able to help with that. And all these things are going on here. So if we can try to interrupt this process, then that will help us to get rid of these cancer cells. Hopefully our immune system will be able to help out and get rid of them as well. And then you hopefully will be cured of cancer, but we'll see that can be, met with varying degrees of success depending on the type of cancer you're dealing with. Typically what you're going to see here is that even just one cancerous cell is able to propagate. So you really want to try to kill every single one of them. And so how we're going to treat that is mainly going to be decided by the type of tumor we have, how disseminated it is, sometimes things like the heterogeneity of the tumor. So do you have multiple types of cancer cells that have different characteristics that may not all respond to your therapies in the same way? And so that's going to dictate how we're going to get rid of the cancer cell, whether it's going to be surgery, whether it's radiation, or whether it's going to be with chemotherapy, which is what we're going to be focusing on today here. But what you typically see with these cancerous growths is they're going to undergo what they call Gompertzian cell growth. And again, I apologize. I'm just trying to get a little bit of background on this stuff, just so everyone's on the same page with me. If this is a little bit of review, then just kind of take it as it is. We'll get to the drugs here in just a little bit. But basically, every tumor is going to have sort of a doubling size that it takes. So it's a pretty constant time that it takes for all the cells to replicate. Typically, faster dividing cells, or the shorter doubling time, means it's more of an aggressive tumor than if it was much more slow growing. Something like the prostate's a lot more slow growing than, say, for instance, your white blood cells with like leukemia. What you're going to find is that early on, when there's not a lot of these cancer cells, they're going to grow very rapidly because they have a lot of nutrient supply, they have a lot of room to grow. But then as they start to outgrow that supply, and as they start to maybe run out of space potentially to grow, they're going to start to see that your growth curve is going to flatten out. And so that's something you'll see where it kind of plateaus. And this is sort of what this would look like if you were to look at this dashed line as just the replication of the cells. You can see here they're just going to continue to grow, and then they'll eventually flatten out. And that's when basically they can't get any additional nutrient supply to it, things just tend to slow down. And so that would be important too, because some of our medications work better, or maybe only work on cells that are actively replicating. So if you have like a big tumor that's sitting there and most of the cells are not replicating, then it may mean that your drugs are not going to be quite as effective, which is not good. So you're going to find that even if you were to like do some kind of therapy, like say you like did surgery and you're going to try to kill off 99.9% of all the cancerous cells, you're going to see that you still have enough left there in order to continue to replicate. And so this is why we do multiple modalities of therapy in order to try and kill off as many of these cells as we can. But you're going to typically need repeated courses of therapy to kill every single one of them. And that can be pretty challenging. And again, too, you can see that a lot of times these cells are growing and they have sort of a subclinical phase where you can't really detect it very easily, which is why things like routine checks for certain types of cancers are important, because it's quite a while before symptoms can really occur here. So we'll look at some ways we can try to combine these different therapies together. We'll see some of the benefits and some of the downsides of that as well here. So the things like surgery are going to be really good if you have like a nice, well-localized, well-differentiated tumor where you can very easily say, yes, this is the tumor. You can try to excise that out. Now it's not perfect because it's very hard to tell if you're getting every single type of cancerous cell. During the surgery, there's some modalities that may be better for this than others. I'm not sure if any of you are interested in derm. I usually have a few, but there's something called like the Mohs procedure, which some of my students have come back and told me about. I'm not really into the derm world that much, but they were telling me about this Mohs procedure where they can actually do histological sampling of tissue that they're removing from the patient if they still see cancerous cells, and they continue removing tissue, and they keep doing that until they basically don't find any cancerous cells left, which is really kind of wild. They can do that, but most of the time we don't have that ability to be that sort of specific in what kind of tissue we're removing. So you try to get the tumor out and hopefully got every single cell, but oftentimes you don't. So you need to be able to combine that with other modalities, because that's really, surgery is great to get rid of like a ton of the cells, but to get all the stuff left over, sometimes we require things like radiation therapy, which is going to be better for more like localized tumors, maybe some that are not so easily removed, maybe like certain types of brain cancer, for instance. But then chemotherapy, we're going to find, is typically something that is going to be much more systemic. Like we're going to get this stuff IV. It's going to kind of get everywhere. And this is going to be able to target all of those like really rapidly dividing cells. You're going to find that it's able to get all those cells that maybe you've missed with radiation or surgery. And so you can see back on this slide here, that you say, for instance, you get the diagnosis of cancer and you can have surgery to remove as many of those cells as possible, but then you have to follow up with something like radiation or chemotherapy. And notice you're going to have sort of a cyclical sort of pattern of giving medication or whatever therapy you're doing. Sometimes if you can't do surgery, then maybe you just start off with radiation or chemotherapy to try to go with these cycles. And you're like saying like, well, why don't we just keep treating until all the cells are gone? And we're going to find that's going to be not possible, mainly because we're going to end up killing off our patients if we do that. So what we can do instead is we'll see that we are going to have sort of a cyclical administration of these things to try to give the patient time to recover before we hit them with another dose of chemotherapy. So what we're going to see is that we're trying to maximize our benefits versus the risk of giving chemotherapy. And by doing that, we can look at things like drug concentration, the exposure time of the patient to the drug, and how frequently we're giving the drug in order to make sure that we're trying to get as much benefit in terms of like killing off the cancerous cells versus risk of causing problems to the patient. And the big thing here you're going to find is that like almost all the cancer drugs that we give are poisonous, right? I don't particularly like chemo drugs, mainly because I went to, my training is in toxicology where we reverse poisons. Or reverse the effects of poison, but here we're purposefully poisoning these patients in order to kill off these cancerous cells. So it's kind of a tough, tough line to balance there. And so a lot of those toxicities mean you're going to be hurting a lot of your own naturally rapidly dividing cells. So things like your white cell count is going to be diminished, right? So it can lead to myelosuppression, it can lead to infection. Your GI tract has a lot of rapidly dividing cells, so all that GI epithelia can be affected, leading to malnourishment, malabsorption of nutrients. It can lead to like oral ulcers and sores like stomatitis that can make it very painful and difficult to even drink water. hair cells will be affected, and that can cause alopecia. I think most people are sort of most classically recognized as like, being associated with cancer treatment. So all these things are, we know that's going to happen. We know we're going to hurt the patient, but again, it's a matter of getting rid of the cancer or, or harming the patient there. So it's a really tough line to balance, as I mentioned. So what we're going to see is that we will typically go with a high dose intermittent sort of schedule, and this will allow for recovery of blood cell lines in between giving these medications, these rounds of medications. And so two of the big things we're going to be looking at include their white cell count, namely their neutrophils. So we'll look a lot at things like the absolute neutrophil count, and we'll also look at their platelet count. That can give us an idea of how well they've recovered. And frequently, we may not be able to give chemotherapy because the patient hasn't recovered yet. So we do this a lot. Where I work at the Children's Hospital, we have an infusion center where patients can come in and get their chemotherapy. And if they don't meet certain cell counts, mainly their ANC and their platelets, we can't give them meds. We have to turn them away and say, okay, we'll come back in another week to see if you've recovered enough. And so that can be really a big challenge in terms of making sure we don't harm our patients too much, because if that ANC is too low, they don't have enough neutrophils to fight infection, then they come in and they have these secondary issues to run into. So we'll talk about some opportunistic infections a little bit later on. But frequently, it's not that the cancer is actually killing these patients. It's oftentimes going to be the secondary infections that they end up getting as a result of the myelosuppression that we cause here. So it really just depends on the type of cancer you're dealing with and things like that. But we also want to make sure that when we give these drugs, we want to make sure that the cancer cells are going to be maximally susceptible to them. And that may depend on where the drug is at in the cell cycle. So if you recall back to your undergrad biology class and talking about the cell cycle, your G1, G2 phase, your S phase, and all that, that's going to become important again. And then also where that tumor is at in the growth curve. So just as an example, if you look back at this slide here, if I have cells that are low, in this kind of lower number range here, you're going to find that they are rapidly dividing. So they're going to be much more susceptible to my chemotherapy, as opposed to if I'm treating way up here in the growth curve, where a lot of these cells are just kind of in a just kind of a rest mode. They're just kind of sitting there, not actively growing. That's not going to be nearly as susceptible, which is why we do things like surgery plus chemo, because that surgery will knock down the cell count, get most of those cells back into a rapidly dividing phase, and then you hit them with the chemotherapy in order to get that down, right? And again, we let them recover. That's mainly to give them time for their blood cell lines to recover. Certainly, some of those cancer cells are going to start to continue to replicate, but again, you take the good with the bad in those cases there. So this is a good slide to kind of go back and visualize where the different drugs are going to be working at. And so when we get into the different classes, most of which of these we're going to talk about in the upcoming slides here, but we're going to find that some of them are very cell cycle specific, meaning they only work in certain portions of the cell cycle, which means it's really important that they are in an actively dividing phase. Some of them are going to be non-cell cycle specific, meaning you can kind of give them whenever and they'll work throughout the cell cycle. They're not going to be so important in terms of timing those things out. So if you recall with your cell cycle, G0 is kind of the resting phase where cells are just kind of not actively replicating. They're just kind of doing their thing. We're going to find G1 and G2 are going to be sort of where things are getting prepared for, mitosis to occur here, where you're waiting, trying to build up protein stores and things like that. Those aren't going to be quite as important to us. The two main ones we're going to be looking at are going to include the S phase, which is where DNA is actually being replicated and reproduced, right? And then the mitosis phase, where you're actually having the new cells being formed here. These will be the two most cell cycle specific important portions here, and that'll become more obvious once we get into the mechanisms of the drugs. You can see pretty clearly which ones work on DNA replication and which ones are going to be more important for working on things like mitosis. And then you'll see why some of the cell cycle non-specific ones can kind of work at any point in terms of their mechanism is just not going to be specific for the S phase or the mitosis phase. So again, just to kind of reiterate that, again, cell division can differ depending on the type of tumor that you're dealing with, the type of cancer you're dealing with. And again, you can find, we'll talk about things like the S fraction, or the fraction of cells that happen to be in the S phase. And that may mean the cancer is more susceptible to certain types of drugs during that phase there. And in fact, sometimes just to make sure that we try to get all of the cancer cells in a particular phase, we may give a drug over the course of a few days. So we'll have regimens where we can give medication as a continuous infusion for like 3 to 4 days straight. And then that will allow for, as new cells start to enter into the S phase, then they will become susceptible to the drugs. And then boom, we can hit them with that and hopefully trigger apoptosis for them. So we will find that most of our cells tend to be more in the G0 phase where they're not actively replicating, but it's really the cancer cells that we're shooting for being in the active replication phase. And we also will find that a lot of the toxicities we run into, some of which I mentioned, are as a result of those rapidly dividing cells constantly being in a state of replication. So like the GI epithelia, your blood cells, hair cells, things like that are constantly growing. Those are all going to be most susceptible to these chemotherapy medications here. As I mentioned, the growth fraction is just that proportion of cells that are actively dividing. So a higher growth fraction means it's more susceptible to chemotherapy. That's good. The S fraction means what percentage of the cells are actively replicating their DNA. That again can imply the aggressiveness of the tumor. And then that doubling time kind of sort of tells us how long does it take for the tumor to double in volume. And again, a short doubling time, meaning they're rapidly dividing, usually indicates a more aggressive sort of tumor. So how do we utilize our chemotherapy to get the most sort of most utility out of them? We try to use oftentimes combination of therapy, and I'll show you an example of what we call a roadmap. A roadmap basically being sort of the regimen that the patient's taking from day to day. We do combo therapy in order to try to get good synergy out of the drugs to make them work better together, and then also to try to minimize their toxic effects. And just like your bacteria can become resistant to antibiotics, your cancer cells can become resistant to the chemotherapy, right? Because they're rapidly dividing, they can make mutations, they can become resistant. So we want to try to prevent that by using combo therapy if we can. And then we're going to see that we'll use a lot of adjuvant therapy, meaning other drugs you're adding onto the regimen that don't directly treat the cancer, but treat a lot of the side effects of the cancer itself. So for instance, nausea, vomiting is one of the worst side effects, one of the most common and most severe side effects you'll see with administration of chemo. And so there's going to be a lot of drugs. I can find some patients on 4 or 5 medications just for the nausea, vomiting for some of these medications here. Some of them we may try to stimulate the bone marrow growth because their neutrophil count is not really recovering or their platelets are low or something like that. So again, these regimens can become quite large, and it's important to kind of understand, okay, what are each of these doing here in terms of, is it treating the cancer? Is it treating some of the side effects? What's kind of doing what here? And so, as I mentioned, the timing of chemo, we're going to find that the cell cycle specific ones are only going to be targeting those cells if they're in the S phase or the mitosis phase here. As I mentioned, we can either give them as multiple doses in a closed time frame, so maybe once daily for 4 or 5 days, or as I mentioned, we can do continuous infusions where we'll actually admit the patient to the hospital and infuse it over that few days that they're there with us. And then you'll find some non-cell cycle specific ones can kind of be given whenever, and they work at any point, so that's not as going to be as time critical. And then we'll give the chemo in cycles, so you'll see that a lot, that they're on cycle 1 or cycle 2 of various phases of their treatment. And this again allows for recovery from the toxicity of the drugs. And again, how we determine what's the optimal treatment strategy here, because again, it's hard to do randomized controlled trials for a lot of these things because some cancers are rare. It's not feasible to do placebo controlled trials because it's not ethical to give cancer patients placebo to see how they do compared to people that do get chemo. But there are a ton of clinical trials going on, and we do this a lot in peds as well, where we will do different regimens to see, okay, what's the right dose, what's the right frequency, and all of that. So if you ever hear of COG in the Children's Hospital, that's a children's oncology group, and that's where we do a lot of these studies here to see how to best treat these cancers. So this is a busy slide, but this is an example of a roadmap that we would use for some of our patients on chemotherapy. I just wanted to illustrate to you sort of how sort of regimented it is, how kind of complicated it can be in some cases. But here at the top, you'll see all the various drugs, and we'll talk about all of these as we get into it. And it'll talk about, okay, how are you administering it? What kind of dose are you getting here? And how frequently are they getting it? And so some things may be very infrequent. So for instance, cyclophosphamide, you're only getting on days 1 and 29 of this particular cycle. It's a 56-day cycle you can see here. Whereas some things you're going to be getting every single day or pretty close to it. So for instance, mercaptopurine, you give it for about 2 weeks at a time here. And so again, they'll go through these cycles, they'll go through these regimens, and depending on how they're responding, then you can maybe move on to another cycle or may slow them down. It just depends on the case there. Notice two different routes for these drugs. So for instance, some of these drugs can only be given via IV, so they may have to come into the infusion center in order to get that. Here's an example of cytarabine given for 4 days straight. So this would be something we'd actually have to bring the patient into the hospital in order to get that continuously. Some drugs are given intrathecally, right? Because the CNS can be a very protected area. Not a lot of things like to get across that because of the blood-brain barrier. So by giving things intrathecally, you kind of give the drug directly into that space to kill off any cancer cells that might be hiding out there in the CNS. So again, just some examples. And again, the monitoring is extremely important for a lot of these drugs because some things can cause liver toxicity. Almost all of them can cause, myelosuppression. So these are things you're looking for just to see, okay, well, how's the patient developing? Are they getting, rate limiting sort of side effects where we had to kind of slow down on our chemotherapy, maybe give it less frequently, give a lower dose, things like that we're kind of all considering as we're going through. So very complicated patients, but very rewarding if this is something that kind of interests you. I think it's a very cool, route of medicine to go into. But of course, early detection is always key. It's easier to treat these patients before you have kind of clinically obvious disease than after. So things like, getting routine checks, mammograms and, colonoscopies and all those things like that you're supposed to get on a scheduled basis is always going to be better if you can get that early and prevent cancer from developing. So as I mentioned, toxicity is a huge factor here. Again, you're killing off a lot of these rapidly dividing cells. So the neoplastic cells, that's good. That's what we want. We want to kill off those cells. However, the myelosuppression, this can be potentially fatal because of the risk for different infections that someone who's immunocompetent would not be at risk for. Things like PJP, pneumonia, and tuberculosis. With the GI tract here, this is a huge one, especially for kids, because of the oral and intestinal ulceration, because all those epithelial cells are just not dividing like they should. So you can see things like stomatitis that can lead to oral infections. You can have kids and even adults who can't drink or eat like normal. So they start to lose weight or they get malnourished. And again, that's not great if you're a developing kid. Alopecia, as we said, which can be quite just sort of psychologically, harmful to the patient. They see all their nice hair's gone. And it's really wild too, because when the hair starts to grow back, sometimes it's like a different texture even. So, sometimes people like had straight hair, sometimes it'll kind of grow back curly. So it can actually affect like the protein structure of the hair, which is pretty wild. And then certainly the reproductive cells can be affected here as well. So you can see things like menstrual irregularities. You may see infertility as a result of this. So again, a lot of side effects, but what's the alternative? Patient's dead, okay, you take the good with the bad, obviously. As I mentioned, there's different ways that your cells can become resistant, or the cancer cells can become resistant to the drugs. A lot of this has to do with the same mechanisms that bacteria can do in terms of like decreasing uptake of the drug or changing metabolism. So again, by giving cyclical regimens, by using combinations of drugs, you try to get around this resistance and prevent it from happening if you can. But we'll look at some other more specific cases as we go forward here. And then again, your goals of therapy may be different depending on the type of cancer, depending on when it is, how late stage it is. And so you have to kind of consider, is this more of a curative type of treatment versus palliative? And so curative mainly being to actually get rid of the cancer. You may see this for more treatable cancers, maybe for younger patients, for more early stage cancers versus palliative. When you're kind of saying, okay, we can't really get rid of this cancer. Patient is ultimately going to succumb to this, but can we do anything to try to improve the quality of life for these patients as opposed to just focusing on the quantity of life? And so sometimes chemotherapy can be useful from that standpoint. So again, whenever each is appropriate, is going to be very dependent on the patient, sort of their stage in life and all of that. So anyway, I want to get into the actual drugs now. Again, this is not an exhaustive list, even though you may be exhausted by the time we finish it. but I want to hit on the really common ones you're going to run into. And again, even if you're not interested in oncology, you have no interest in ever working with these patients, you may still run into them with some regularity. Right? If you do family practice, internal med, ER, anything like that, these patients are still going to be coming to see you for their other issues, right? So they may see their oncologist for their breast cancer, but they're seeing you for their diabetes, for their hypertension, all that other stuff. Or if you're working in the ER and a patient comes in with a suspected pneumonia and they're on chemotherapy, well, is it because of the chemotherapy that they're developing this pneumonia? Do you need to now consider things like TB because they're immunocompromised? So by being aware of these drugs and kind of knowing what kind of side effects to expect from them and things like that, it can help to enhance your practice, even if you don't directly prescribe these medications for these patients. So again, why it's very important to be aware of these things, because again, you'll find these patients everywhere. So starting out, we're going to see that different places for our medications to work. And so we're going to see some of these are good at working on production of nucleotides to introduce into the DNA. Some of these affect DNA replication directly. Some of these work on the mitosis phase. We're going to get into all of these, and we're going to see different ways that these work, and you can see how these can be synergistic with one another. This is a good slide to come back to once we've covered all of the drugs. And again, if I cover them specifically on the upcoming slides, and those are the ones I want you to know for testing purposes. If you see one on here that I didn't talk about specifically, then don't worry about it. Again, I'm not covering every single one of these because that would, honestly, you could do an entire class just on chemotherapy. In fact, that was like a semester-long elective back when I was in school, because again, there's so much depth that you can dive into with this stuff that I just want to kind of give you the survey sort of course for this stuff, and hit the common ones you're going to be seeing kind of most frequently. So first off, we're going to start off with the antimetabolites. This is going to be basically drugs that are pretty similar to the nucleotides that make up DNA and RNA. And what you're going to find is that frequently your body can't really tell the difference between these drugs and the naturally occurring nucleotides. And so if you can introduce these antimetabolites into the DNA itself, they oftentimes will act as what we call chain terminators. And what that means, it sounds pretty cool, but it's basically where the nucleotides get added on, these false nucleotides get added onto the DNA, and then they lack usually the sugar aspect of DNA in order to add on any other nucleotides. So they kind of, once they get incorporated, they kind of stop further propagation of the DNA. And then the cell's going to detect, hey, there's a problem here with this DNA, and hopefully you cause enough damage to where the cell basically says, hey, this cell's no good. Let's go ahead and just trigger apoptosis and get rid of it, right? That's the ideal thing you would like to have happen. And so what we're going to find is that with most of these drugs here, they're not selective just for cancerous cells. They can affect healthy cells as well, which is why we see a lot of the toxicity that we do. And again, why we have to give time for the patients to recover between when we give these medications here. So some of these may look familiar, like we'll get into a folate antagonist we talked about previously. But the three main categories we're going to look at are going to include the Pyrimidine Analogs, Purine Analogs, and the Folate Antagonists. Excuse me, I'm trying to hit the button before I sneeze directly into your ears. Anyway, so those are the three main categories that we're going to be seeing with that. So let's start off with the Pyrimidine Analogs. And again, some of these changes are so subtle, but it's so interesting how big of a difference it can make to the body, because it can't tell the difference between these various nucleotides. So for instance, here is an example of what cytidine would normally look like. Here's deoxycytidine that could be added on to the actual DNA itself. And then here you have cytosine arabinoside, otherwise known as cytarabine or Ara-C. You'll also find there, just like with HIV, there's a lot of abbreviations for drugs. So I will give you the generic name and then the brand name on the test. I just list here the abbreviations just for just to kind of get you acclimated to it, just so you're aware of okay, if you see acronyms, look them up, because again, it's very easy if you work in oncology every single day, that's just an easier shorthand to refer to them by. But when you're dealing with someone who's a novice to the field, it can be very easy to get bogged down in the different abbreviations, and you can potentially get some misunderstanding happening there. But anyway, if you're looking at cytarabine or Ara-C, notice here they just flip the position for the hydroxyl group here. Like, it's a very small, subtle change. You may think, okay, well, what's the big deal? How can that potentially cause any issues? But again, once it gets incorporated into that DNA, it cannot cause any further lengthening of that DNA. It's basically stuck. So in some cases the DNA polymerase can fix that. Oftentimes it can't, and that's what triggers off apoptosis and kills off the cell. So the first one, as I mentioned, cytarabine. It's a cytidine analog. Now I don't really care if you know specifically which nucleotide it's an analog for. I just want you to know the mechanism. So if you see cytarabine on the test, okay, I know that's going to be an antimetabolite. I know that's going to be something that's going to disrupt elongation of the DNA, basically, right? So it's acting as a chain terminator. It's going to trigger off apoptosis by causing enough damage to that DNA. And if I list routes, that is just, again, to get you sort of just kind of wetting your beak, so to speak, in terms of getting you some exposure to that. I'm not going to ask you specifically which ones can be given intrathecally. I'm not going to ask that on the test. Just to give you ideas of different ways that patients could be receiving this. And if I get into indications, again, I'm just listing it just for example. So that way, if you like, oh yeah, I had a family member who's on this drug. Oh yeah, it makes sense. They had leukemia, right? So I'm not going to get really specific into the indications. But the things I will harp on are going to be things like your mechanisms, the side effects, the interactions, those sorts of things. Toxicities are very important. And if there's any antidotes to the drugs, those are good things that I can harp on. Because again, I'm not going to get so in the weeds that I can say, okay, the patient has Hodgkin's lymphoma. Which drug do you want to use? That's not the purpose of this course. It's more to get you acclimated to the drugs, and you may get that elsewhere in your medicine courses potentially. So anyway, so toxicity here, you're going to find some of these things are going to be ubiquitous amongst all these chemotherapy drugs, right? So it's going to be sort of not worth your time to sit there and remember, well, which one of these cause nausea and vomiting? Because they all cause nausea and vomiting. Like, that's just going to be a natural side effect of chemotherapy, right? Now, are some more emetogenic than others? Absolutely, right? I'll talk about some examples of that later on, but I would say for your purposes, as when you're studying for this stuff, is to focus more so on what are sort of like the unique side effects. What differentiates this set of drugs or this particular drug from some of the other ones that we looked at? And I think that'll be give you a better kind of high yield in terms of your time and what you're going to focus on while studying here. Okay. Again, nausea, vomiting, mucositis. That's going to be common with any of these drugs that are inhibiting replication of those GI cells. Again, the body detects these drugs as poison. That's why you get the nausea, vomiting. It can trigger off that chemoreceptor trigger zone in the brainstem. So again, these are all things that you expect with most of these drugs here. Now, things that could be seen as unique to something like cytarabine includes the cerebellar syndrome, where basically they can start to have this neurotoxicity where they can have things like dysarthria, nystagmus, and ataxia. This is oftentimes seen with patients with more with like renal dysfunction who can't clear the drugs as well. And then another thing that's interesting too is you can actually see a lot of conjunctivitis and keratitis associated with this. Patients are just not making as many tears as normal as a result of the drug, and so we can either give them like supplemental like saline eye drops. Sometimes you have to use even steroids if they're getting really bad conjunctivitis, and so that can be useful as well to treat those particular side effects. But again, if they're starting to develop that, I'd probably get my ophtho friends on board as well, just to see if they can provide any sort of assistance as well, because you want to be careful using those ocular steroids. In terms of other pyrimidine analogs we have here, we have gemcitabine. This is also structurally related to cytarabine, but if you notice, instead of having that misplaced hydroxyl group, it just puts two fluoride ions here, right? And again, your body can't really tell the difference between this and the normal cytarabine. So again, it's going to get just kind of incorporated, or I'm sorry, the cytosine. So it's going to be able to just get incorporated in, and then it's going to be able to block further replication of that DNA, right? So it's going to select as a chain terminator. And again, pretty similar side effects is what you're going to see with cytarabine. Notably here with this one, it can actually cause a lot of flu-like symptoms. And so frequently, if you have side effects like that, just give them some Tylenol. That'll help out with any kind of mild fever they're having. It'll help out with any sort of like, arthralgias, myalgias that are developing there. And that is generally sufficient. And usually around when they're giving the medication, then it normally dissipates. So again, sometimes we'll do what we call pre-treatment. for some of these drugs where if we know they're going to have certain side effects, we'll go ahead and pre-treat them with things like Tylenol beforehand, and that can be helpful to sort of mitigate those side effects before they really develop. Another one here called 5-fluorouracil, which is oftentimes abbreviated as 5-FU. Again, I did not make that up. That is something that is, I don't know who did that, but I think it's kind of funny. But, and then there's another drug that's kind of structure related to that called capecitabine or Xeloda. Sometimes these are done in different forms because they may have different dosage forms available to them, like they maybe oral, maybe just IV. Depends on the case here, but basically, again, this is acting as a false pyrimidine. In this case here, we're actually getting incorporated into RNA to inhibit its function, but it can also inhibit this enzyme called thymidylate synthase. So basically, it's preventing formation of thymidine, which we know is important to getting incorporated into that DNA. So we're going to see during this process here different ways that this can be interrupted. We'll find that folic acid is really important for this cycle here, so we'll see where methotrexate comes into play. But 5-FU specifically will inhibit that thymidylate synthase unless you don't have any of that thymidine to incorporate into the DNA. So that's an important step to your interrupting there. You'll see this a lot for different types of leukemia that are out there. But again, looking at the toxicities, dose-limiting leukopenia, diarrhea, mucositis. Yep, we've seen that already before. So again, that's going to be the case for the majority of these drugs here. Again, we can see a cerebellar syndrome, similar to what we see with cytarabine, as we saw earlier. Some of these drugs can cause what we call a hand-foot syndrome, or you may hear of like a stocking glove syndrome. That refers to a neurotoxicity that you can see that predominantly affects kind of the longest nerves that you have, and that typically is going to be out to the limbs. And so sometimes they can develop a paresthesia, typically like in the fingers or in the toes, that can sometimes be reversible, sometimes not. Oftentimes, if we start to see that hand-foot syndrome develop, we might try to find a different drug that we can use, or maybe try to reduce the dose. That way we can try to mitigate that as best we can. So that's one thing we'll see that pop up a couple of times in these various drugs here. And then again, that conjunctivitis can be a problem for these patients. So if they're complaining of eye pain or eye discomfort, again, look at the drugs they're taking, and that could be a reason for that. Switching gears to the purine analogs. So again, I don't really care specifically if you know if it's a purine versus pyrimidine analog. I'd rather you know that it's an antimetabolite, and I'd rather you know the mechanism for the drug here. But here we have a drug called 6-mercaptopurine, which is oftentimes abbreviated as 6-MP. And then another drug called thioguanine, which is structurally pretty similar, similar actions here. And so again, they're treated, used to treat a lot of different types of leukemia. So again, acute lymphocytic leukemia primarily is where I see it most often. And just a disclaimer, which I don't know if I mentioned already, I mainly deal with pediatric oncology. Stuff that happens with adults, I really have had very little exposure to. So if you see something done differently for adults or something like that than what I'm saying, it's probably true. It's just a matter of perspective here. So, and again, the types of cancers you're dealing with are quite different between peds and adults, right? Like I don't see any prostate cancer, I don't see any breast cancer and things like that. Whereas we see a ton of leukemias, like kids get leukemia much more frequently than a lot of other types of cancer, a lot of osteosarcoma, things like that. So again, my experience is a little bit limited, but the drugs do the same thing regardless. It just might be dependent on where you work and what they're being used for specifically. So just FYI on that. So anyway, so here you're going to see they can, again, get incorporated into the DNA, and they inhibit that DNA polymerase from being able to add on any further nucleotides. So the mechanism is near identical to what we saw with something like cytarabine. Some of the issues you're going to see with 6-mercaptopurine and thioguanine specifically are going to be this hepatotoxicity. You really do have to watch liver function to make sure that's not starting to go the wrong direction, meaning if you start to see the LFT start to skyrocket, this is something you may not want to continue on. And also it's kind of interesting too, there are some pharmacogenetic changes that could be present in certain patients. So some of them could have certain polymorphisms that make them more likely to develop toxicity than others. So this may be a case where you're doing some genetic testing prior to starting the drug to see if they're going to be more likely to develop this or not. And then maybe you adjust the drug level, or maybe even change to different drugs potentially, depending on the situation. And then the last antimetabolite we have here is our folic acid antagonist. This is going to be methotrexate. Again, I use this all the time for a lot of kids with leukemia and certain types of lymphoma. But we've already covered this previously when we talked about it in terms of rheumatologic conditions. So we hit that back in the beginning of the semester here. So big differences you're going to see between methotrexate used for things like rheumatoid arthritis versus for cancer. With rheumatoid arthritis, we're really just trying to like kind of tamp down the actions of the immune system to just decrease the amount of inflammation that is causing at places like the joints for RA. In the case here, we are trying to kill off these cells. So typically the doses that you're seeing are going to be much more intense than what you would see with someone who just had, rheumatoid arthritis, just getting methotrexate maybe, once a week or a couple times a week. These doses are going to be much higher. So the side effects are also going to be much more pronounced when they're getting these really big doses here. So again, how the drug is working is interrupting the recycling of folic acid. Basically, these cells will not be able to form the active form of folic acid called folinic acid. And because of that, you're not going to be able to form those new nucleotides like thymidine. So by disrupting that, you're going to have decreased DNA and RNA production. So a big difference here with the mechanism for this is that we're seeing decreased production of the nucleotides as opposed to something like cytarabine, which is the false nucleotide, getting incorporated in the DNA and then preventing any further elongation, right? So kind of keep the mechanism straight there from one to the other to have an idea of, okay, what differentiates these? Does it make sense that you could use methotrexate plus cytarabine together at the same time? Well, yeah, it does, because they have different mechanisms that are complementary to one another. It may not make as much sense, though, to use something like cytarabine plus, for instance, gemcitabine, because they're doing the same exact thing. So those are things you want to kind of consider when you're comparing and contrasting these various drugs here. And methotrexate, we give it all the time, orally, IV, intrathecally. There's lots of different options you have available there, for sure. Sometimes we'll give it as like, a 4 or 5 day continuous infusion. It just depends on the protocol and what type of cancer that you're dealing with there. So toxicities can be pretty significant here for methotrexate. We know myelosuppression, we know GI toxicity here. Also, methotrexate tends to be pretty rough on the liver, so definitely monitor your liver function. So far, 6-MP and methotrexate have been the big ones we've talked about so far for causing hepatotoxicity. The other thing you really have to watch out for in terms of organ toxicity is the kidneys. What you can find is that when you have patients who are especially getting really big doses of methotrexate for cancer purposes, is that you can actually cause the drug to precipitate out in the renal tubules. This would be a form of intrinsic kidney injury happening here because they are precipitating out and causing all these little methotrexate crystals to directly damage those cells in the renal tubules. So one of the things we can do to try and mitigate that is to either, one, give them lots of fluid. So typically you'll see these regimens include a lot of IV fluids that are helping to hydrate the patient, but also we'll do things like adding sodium bicarb. Adding sodium bicarb will help to alkalize the urine and will help to prevent precipitation. Methotrexate tends to be more soluble at a higher pH, and so if you can bump the urine pH from like say 5.5 up to like 7.5, that greatly increases the solubility, and then you can just pee out the methotrexate, no problem there. Sometimes we'll also run into some protein binding interactions here, which can also increase toxicity. So that's one thing you'll see occasionally as well. In terms of antidotes, this is the first time we're seeing antidotes here, so this is important to note. Be able to recognize which antidotes go with which drug and what specifically they're doing, right? So in the case here, sodium bicarb, we'll call it an antidote, but really it's just helping to increase the elimination by making sure that drug doesn't precipitate out, right? We do have another couple of options here. So if you wanted to help you or help the patient and rescue healthy cells that are being affected by methotrexate, just like it's affecting cancer cells, we can actually supply them with the folinic acid, the active form of folic acid. So that way they can utilize that to produce new RNA and DNA. Another name for folinic acid is called leucovorin. So you may hear like a leucovorin rescue. And this basically just bypasses the folic acid or folate, the need for folate, and by bypassing that dihydrofolate reductase enzyme. So it skips that step because you're already giving the active form already. So it's more expensive than just giving regular folic acid, but again, it's good because you can help your patient recover from those really big high doses of methotrexate there. Now, some people will say, okay, well, aren't you helping out the cancer cells as well? Yeah, to a degree. But again, you're having to balance harming your patient versus harming just the cancerous cells. And so you got to give them something to help and save some of those healthy cells as best you can. So frequently you'll see they'll give maybe like a day or two worth of methotrexate. And then after a certain period of time, then you give them the folinic acid. So you give it time to work on the cancerous cells, which are actively dividing. Then you hit them with the folinic acid to try to recover some of those healthy cells. So again, different ways you can utilize that. And then for like really severe cases where maybe a patient's renal function has led to them not being able to clear the methotrexate at all, maybe they have acute renal failure, or if they maybe have an accidental overdose and someone gave too much on accident, we have a drug called glucarpidase or varaxase. And this is actually is an enzyme that you can administer IV that will directly metabolize methotrexate to a more water-soluble form. Again, very rare that we use this, and it's quite expensive. I think it's on the order of a single dose being like $100,000 plus. So it's very rare that we use that, but very helpful if you have a patient who's really in dire straits from that standpoint. So those are the antimetabolites, right? So you have the Purine and Pyrimidine Analogs, and then we have our folic acid antagonists. Those are the main antimetabolites there. They oftentimes will be the sort of the backbone to a chemotherapy regimen. You'll see them pretty commonly in a lot of cases, at least in the cancers that I see being treated, mainly leukemias and things like that. I'm going to go ahead and cut it off here for this week. This is a good stopping point before we get into some of our other drugs that work elsewhere in the cell cycle, things like mitosis and whatnot. But we'll get into that next time. Does anyone have any questions regarding anything we've covered today? A little bit of sort of review of cancer principles and chemotherapy principles, and then, kind of wetting your beak. So a little bit with the first set of medications there. In terms of the exam, I will be reviewing that and seeing if there's any givebacks or anything, any miskeyed questions. And then I'll put an announcement out sometime today or tomorrow, letting you know the results, if there are any givebacks or anything, and we'll go from there. So any questions from anyone? You guys are my quietest group, so either I'm just going to assume you're just all geniuses and you've got everything down. You have just no questions. You're like, this stuff is easy, no problem. Or perhaps I'm teaching it so well that there's just no questions left. I've completely wrung the towel dry of all facts and given them all to your brains. I doubt that, but who knows? All right. Well, I am not seeing anything. So, if you have questions, feel free to put them up on the board. I'll get to them next week. Otherwise, if you have more pressing questions, you can email me and I will get back to you. Otherwise, I will see you all next week. So I hope you have a great rest of your week, good weekend, and I will see you next Tuesday.